Okay, I'll continue with the same procedure for the mandibular rim. I've checked that my base plate is very stable. It's not engaging any undercuts. I haven't scraped any of the final impression. I haven't injured any of the anatomy that's necessary. That was replicated nicely in the final impression. Sometimes if we have some bony spicules from recent extractions or some sharp ridges, maybe your base plate needs to be blocked out to alleviate and minimize the risk of breaking the ridge off the model. So as I can see the attachment where I put the attached and detached mucosa, I'm overextending the wax, and I'll re-contour that border after the wax has solidified from my rim. Now, as I cautioned earlier, this is just one way to make the occlusion rim. It's not the only way, but the results I find here are a practical, pragmatic approach to an occlusion rim and creating an occlusion rim for what the practitioner needs it for. I need it to go into the patient's mouth comfortably, so I don't want to waste chair time adjusting like your base plates or hard bony undercuts. I want it to be comfortable for the client, so therefore the practitioner can move about quickly and establish vertical dimension, check for labial contour of the rim, demarcate all our occlusal rim necessities like midline, cuspid line, high lip line, low lip line, canine line, and then move forward with the face-bow record, protrusive record, and lastly the centric relation record, which will mount our models. Now, for simulation purposes, I'm sure you've noticed that these models are on a mounting ring already, but I've already done the liberties of using an aesthetic control-based occlusion rim for my setup, and now going backwards one step, creating an occlusion rim again for video purposes. So in case you're wondering, saying, hey, this guy's model's mounted already, how did that happen without an occlusion rim? Well, please suspend some disbelief that the bite registration was taken already. Just going back and creating an occlusion rim for video purposes, something that may help you on the next one if you've already created your occlusion rims and achieved your bite registrations for this project already. So the same procedures already. As you can see, I was very liberal, very hot flowing wax all the way down, very thick too, not just a thin layer that may peel away and delaminate from the main wax sheet. You can see even in the video, I'm sure it's very molten here. I've got my upper here setting on the side while I'm creating my lower one. If you want to do something differently, you can fold the wax here, squeeze out any air pockets. If you choose not to fold, you can roll. Regardless, the whole idea is to eliminate any kind of air voids within the wax. So I did some folding, some rolling. If I have any voids, they'd be very small, and I will adjust them afterwards. Now, the sheet of wax was created in such a way that usually one sheet would be one rim, depending on the size of the maxilla or mandible, but it's pretty close. Unless you've got something really giant size, then you would maybe need to add a little extra wax. But for most of the time, I think the one sheet of wax will suffice for the mandible and mandibular. Most of the time with excess. So I'm going to reheat this wax on the model here. You can see with my alcohol torch, filling in the vestibule areas with soft wax. I've created this horseshoe pattern of the sheet wax. I'm going to, with my hands, while it's molten soft, extend it down to the sections that I need it. The more you can do, I think, by hand, the faster it will be. And then you have to have some dexterity to kind of, get me in the right shape. It's going to replicate the shape of the ridge. The mandible occlusion rim is on the ridge. I'm not way off the ridge out here. So if you got your landmarks marked on the back of the model where the center of the ridge is, then you can kind of eye where this occlusion rim is going to be. As the upper, I will angle the posterior section down, and I would only put the occlusion rim where I think the occlusion will exist. The occlusion will not exist on an inclined plane up the retromolar pad. This area is reserved for tongue space, possibly a retromolar. The tuberosity from the maxilla will fall into this place, and for bite registration purposes, I don't want any interference at the back here that the practitioner might not be able to catch when they're putting this occlusion rim in, trying to take registration records. So I'm thinking 8 to 10 millimeters would be the width of the posterior section of a mandibular rim. You could keep it 6 to 8 in the anterior, slightly narrower, or you can keep it consistent all the way around. I mean, some people are really adamant on their measurements, 8, 9, 10. As long as it's on the ridge and the height is 18 millimeters and 2/3 retromolar pad is the estimated. Now, these are all just estimates. The practitioner is going to change your occlusion rim, but I'm giving them something to start with. It's going to give them a fighting chance. Give me the right vertical dimension, right centric relation record. So my try-in is very close to processing straight away. I'm using a hot spatula now, sealing the original free-flowing wax with my rolled wax, hopefully making it homogeneous, that there's be one. I don't want there to be a seam, that it looked like that you can see the two layers. You can see I've got wax on the model here too. Try to be neat. I mean, if my model is soaked, you can see that just peels off so easily because the model, it has been soaked in water. Wax is not going to stick to the soaked model. I'm going to take my rim former, as I did with the maxillary, heat up the rim former, try to keep the rim or the occlusal surface of my mandibular occlusion rim parallel to the model base, which I know is parallel to the ridge because I trimmed it. We need to heat up a little bit more here. And keep in mind our measurements of 18, which I still have room. This is about 20. 2/3 retromolar pad is just a rough estimate, assuming the patient has retromolar pads that are vertical. Sometimes they're very flat and are eliminated from any use to the estimated occlusal plane. Remember, the practitioner is going to take these two occlusion rims, create the vertical dimension, centric relation record, plane of occlusion, buccal corridor, labial contour, that will help us in the setup. I'm going to heat this wax up here. Now, the occlusion rim is not finished, but it's taking good shape. And naturally, the quicker you are, the more efficient that would be. There is no rush. I mean, unfortunately, the occlusion rim is not a number one source of monetary revenue for the laboratory, but it is somewhat of the lost leader to the final charge of the prosthetic, of the complete upper and complete lower denture. Unfortunately, this time taken to create the occlusion rim as well as the custom tray, but these things are necessary in order for us to achieve the final prosthetic. Yeah, somewhat of the lost leader, depending on the time taken. That's usually why it's the entry-level technician's job at first, is to create these diagnostic equipment for the practitioners. So there's my mandibular occlusion rim taking shape. While this one is setting or firming up, I can reintroduce the maxillary. The work area a little cleaner here so the wax doesn't adhere to any base of my rims and models. And now here I would take my, this is a personal choice, I would use this 7R wax knife. Some people will choose to use this one. I find that this angled edge really doesn't create a nice flat surface. This 7R you can see is almost 90 degrees to the plane of occlusion. And then I've seen this knife used, which is more of the plaster knife for the flasking. I mean, there's 3 choices, but I think this one here would be my number 1 choice. But you choose whatever works for you. Naturally, I wouldn't use a small spatula or a small knife to do a large job. Naturally, the smaller job we use a smaller spatula. Bigger job, we use a bigger spatula. Just common sense. So I'm just shaping off some of the nodules of wax, using my hand and the knife at the same time to create the occlusion rim's shape. I haven't taken it off the model yet. I know it's going to come off. I may injure the area, or let's say bruise the land area taking it off, but I'll repair it if there's an undercut that doesn't let go. I got to be really careful in this area with my knife so I don't cut any of the frenums and change any of the master model shape. I'm going to take some wax off the land area here with the outside of my number 7 spatula. You could use your Zale carver, you could use number 7, you could use any kind of instrument that would just take some of the excess off to alleviate the model, or excuse me, the occlusion rim from coming off the model. Now I had some wax posterior to my major connector because, or the palate, the practitioner can contour this. There's a gag reflex, they can shorten it, they can lengthen it. It's comfortable for the patient. It's tapered like a full denture would be finished at the back, increasing the patient's confidence throughout the treatment prior to the prosthetic being completed, that they're moving in the right direction. So I've taken this now slowly, gently off the model. You can see from the tissue surface, I've even had my blue line that I've drawn on the model replicated onto the occlusion rim, and that can give me a little guide to reduce my flange to that extent if I deem that my occlusion rim is overextended, especially in the frenum areas. You can heat up your knife if the wax is a little bit stiff and you don't want to crack the wax or break it or have it flake away. But the 2mm roll, I guess that would be textbook of having a nice flange all the way around, but at least it's consistent. Have that labial buccal roll of wax consistent. Have that flange consistent thickness. Now naturally, if this was border molded, we may have a thinner flange buccal to the tuberosity if the border molding undergone some lateral excursions, which usually that the ramus of the mandible would come up here and compress this muscle attachment area here. This is usually a little bit narrower in this buccal pouch or buccal to the tuberosity. If I've got some places where I didn't seal it quite here together, I can add some wax, kind of simulate this as one here. I had this piece earlier break off on me here. I was a little bit heavy-handed. I'll go ahead now and put it back together. Whatever you do, don't get the hot spatula in the fitting surface. Don't change the fitting surface. If you've got a little bit of flow from the shrinkage of your like your base plate, I guess you could go and kind of simulate that it was uneven. Take off any flaky pieces. I don't want any wax flaking in the patient's mouth. Possibility of them aspirating wax, chewing wax, tasting wax, any pieces coming off in their mouth. That would not be a good situation. Again, you want to increase the patient's confidence throughout the treatment. You don't want any of negative aspects chairside. You want the procedure to be quick. Usually we're dealing with the geriatric when it comes to full upper, full lower dentures, and them sitting for long periods of time, not really a good thing. So we want to be able to get the client in the chair quickly, comfortably, get all the information we need, and move on to the next steps of the prosthetic fabrication. So as you can see here, I can take my time, recontour the rim. I was slightly a little short here due to my land area being a little high on my bead and box final impression. So I'm just going to add here where I've kind of created a little crack or indentation and void here. Seems like there was some shrinkage. It was a little bit short, so I'm going to add some free-flowing wax. Possibly not ideal, but at the same time it gives me an opportunity to kind of heat the anterior section up to see if I have any voids. But I want this labial contour to be really symmetrical of my rim here. As I said, I cautioned you not to put a hot spatula onto the fitting surface inside the borders of the maxillary rim or even the mandibular rim. We don't want to alter the fit of this rim on our model nor in the patient's mouth. We want to create the stability. But I am free to lightly alcohol torch the labial and buccal side of my rim. Maybe on the safer side, we could put it back on the model and lightly alcohol torch to give it a smoother appearance. Now, I've seen from the school days of people taking stockings and paper towels and soap and trying to smooth out the wax. Whatever or any of those procedures that help you make this rim look machine-like, smooth, utilize any of those techniques that will help you. I'll lightly alcohol torch any of the knife blade sharp edges I've made. Careful to maintain my measurement, 22. I'm going to add one for the sulcus. There's 22. 8 to 10 here. Right on 10. Right on 10 and a half. But that gives me a little bit more to play with. I'm using my hands, my fingers to smooth out the rim. If it helps you with the rim former or alcohol torch as well, you can utilize all those techniques. Oops, I had some wax on my thumb. And I'll smooth that off. Anything on the model, for presentation purposes, we don't have wax on the model. It's going to go in the dental office. Disinfect this for delivery, and it is ready for those 3 registrations, as well as review midline, cuspid line, high lip line, labial contour for anterior extension of the anterior teeth, lip support, phonetics, as well as the length for vertical dimension, And this high lip line will also give us a idea of ordering the length of the teeth for this client. So aesthetically, upon smiling, we don't see a big gingiva shown in the smile area here in the aesthetic zone. And this rim here, we could continue on, but I think this would be a acceptable occlusion rim. I can move here a little bit of for the next step. I'll move on to the lower one and carry on the same steps. So once these rims go for those registrations, if we have no face bow, like I said, we will use the average value mounting jig, which average value would be 110 millimeters from the central incisors to the condyle. Our articulator is 110 millimeters intercondylar distance. I mean, this is based on theories of von Mills triangle, which is the average values. So we can at least get the proper opening and closing arcs with the condylar guidance. If a protrusive bite record is not provided by the practitioner, just centric relation, then I'm thinking 30-degree average of condylar guidance seems to be an acceptable value to use. And then obviously if we're using a 30 or even a 20 condylar guidance, we know that Bennett shift, the average horizontal guidance divided by 8 plus 12, will give us a reading close to 15 degrees for the Bennett shift, which seems to remain fixed on our semi-adjustable articulators, because the difference between 14 and 16 is very difficult to find on our articulators. So we will leave that at 15. If we're using a plain line hinge articulator, that's already fixed at 15. So Bennett shift is not going to change. If we're using a semi-adjustable articulator, intercondylar distance is not going to change at 110. And if we're going to use average value mounting, we will use our jigs, which we've created, whether it's a Hanau articulator, Stratus, Amann Gerbach, Danar, any of the articulators. We will put them at 110. So it's really imperative that the dentist use labial contour so we know where the extent of the labial of the centrals will be, so we can mount that accordingly into our articulator. So as we did on the upper, we can take the lower off and with a knife shape all the borders ever so carefully, not to kind of crack, break, flake, voids. If I have any, carefully, gently, dental technology like, you can fill in any voids or any kind of areas that you felt there wasn't any adheration between the earlier wax and the second amount of wax. Now, usually this happens because we didn't use enough wax in that first layer. I've seen some people do it, they do a very thin layer, and I'm like, well, that's just going to flake away. It has to have some thickness, some body to it. Be careful, like I said, don't go into the fitting surface. Don't go inside the flanges, into the intaglio surface of the denture. This is going to change and obviously alter the stability of the rim, and that is not what we want to intend to do at all. The stability of this rim is imperative, so the stability and replication of our vertical dimensions and centric relation records are very accurate to our try-in. I mean, we have enough things already working against us, from the percentage of deformation from the calcium sulfate or the stone, percentage of deformation from the base plate light cure, the deformation percentage of the wax from the temperature change. Then we're going to move into the percentage deformation of the acrylics, whether we're using an injection method, pour method, split flask method. There is a percentage of deformation of some sort regarding what technique we use. So we really need to be eliminating any of these and working close to accurately as possible to get this stability of the denture. I mean, if we're going to go to the painstaking points to see 0.5 millimeter of balancing contact that's out, that 0.5 millimeter can be, you know, from the wax stage to the injection stage to the trimming stage to the deflection of the submucosa. If the patient's tissue is mobile up to 0.5 millimeter, possibly even surgery would have been better treatment plan to kind of eliminate any kind of mobile tissue and eliminate these attachments of the attached mucosa and minimize these land areas that they would be not so large to maximize the stability of the denture. But most of the time, the client in the elderly or geriatrics not going to undergo any of these kind of preliminary surgeries for dentures. Their expectation is, please give me a denture similar to my old one so I can continue eating. So the denture is not just for eating and aesthetics, it's also to rehabilitate the temporomandibular joint, to get the patient in a more retruded position, get the head of the condyle in the uppermost, midmost position of the glenoid fossa. The TMJ for temporomandibular joint rehabilitation. The patient's been wearing dentures, they're losing that anterior stop. Many patients will end up as an acquired class 3 occlusion. We have to be aware that as dental technicians that most clients skeletally or congenitally, only maybe 1% of the population is a class 3. But because of previous dentures losing an anterior stop or losing any kind of centric stop, the patient really functions more anteriorly, therefore causing it to look like an acquired class 3. So now the practitioner says, are we going to keep this client as an acquired class 3, or can we try to rehabilitate them more retrusively and retrude the mandible, retrude the head or neck of the condyle in the glenoid fossa of the TMJ? Can the TMJ joint be rehabilitated? If they are a true class 3, then their horizontal movement is minimized, up to 2 millimeters maximum, if they are a true class 3. If they're a class 2 client, congenitally, skeletally, the class 2 client has a phenomenon where they can have mandibular range movements up to 10, 15 millimeters to move their mandible forward, to contact the anterior teeth, to bite, bring the teeth back, bring the food back onto the posterior section, posterior teeth. So I undergone the same procedures. Any way I can, trying to make this occlusion representable. 18 millimeters, 8 to 10 in the posterior, all the way around even, standardized measurements on the ridge. Any voids of wax for presentation purposes, like here I have on the retromolar pad, I can heat up, eliminate them. And I don't want to give the practitioner a rim that is 27 millimeters versus 18, let's say, as an example. They will spend way too much time chairside adjusting the vertical dimension of the rim. I had a few extra millimeters to work with, so I'm just going to reshape the rim down to 18. Use my knife. I think I'm guilty of using my forefinger and thumb many times, of just trying to shape it. I'm looking at it from different angles, because from different angles I can see that I'm off the ridge here, over there. Angle that back section down a little bit more clearly. I don't want to have any interferences in the posterior section of these rims, which could give me an eccentric reading. Sometimes the practitioner can't see that far back intraorally. There may be some premature contact. As well, sometimes in overclosure, there could be premature contact from the tuberosity to the retromolar pad. So therefore, I've added wax over the extension of my light cure. So this could be adjusted really quickly if overclosure seemed to be an issue, or the patient's vertical dimension has been so collapsed that the practitioner cannot restore to the proper vertical dimension. So we've got some rehabilitative vertical dimensions with the preliminary denture, possibly opening the bite 1 to 2 millimeters, and then treatment plan of opening the bite a further 2 millimeters in the future years to come. But this will be a lot of issues back here in the retromolar pad. As you can see, I've just broken the wax off. And then I'm going to add some wax back here where I flaked off my first area, but sometimes that is the difference between a good day and a not so good day. So, once this cools off completely, reshape it, lightly alcohol torch it again. Just try to give it a smooth surface, whatever technique you want to utilize to give me a smooth, machined surface. So when the patient sees this, the dentist looks this, they open up the delivery box and they see these rims are like, wow. Presentation is very important. The borders of the denture here, if they're overextended, I can double check. I can go back here. Don't make any sharp borders. Try to keep the 2 millimeter border that we talked about, something really smooth and rounded. If it's overextended here into this muscle attachment of the masseter, I can reduce this if I'm overextended. I mean, yes, there is some level of guesswork, but we have a educated guess if we have a strong foundation of anatomy. The frenums here, I need to recut out a bit. There's a little bit too long. I want whatever I can do to minimize the time in the chair for the practitioner. I think that would be valued. And this occlusion rim, if not created correctly, can also exacerbate and extend that chairside time. Okay, thank you.